Hi everyone, thank you for joining us on today's webinar. It's time to ditch the disc, improve patient care by eliminating CDs, hosted by SIIM and sponsored by Ombra Health. Before we get started today, just a few quick reminders. This webinar will be archived and made available to SIIM members under the education section of the SIIM website. Additionally, Ombra Health will also be sending out an email with a copy of the slides and the recording as well. If you have any questions during today's presentation, you can send them over in that chat box at the bottom of your screen, and we'll be answering questions at the end of the presentation as well. So with that, we're going to go ahead and get started. I'm going to hand it over to today's moderator, Morris Panner.
Thank you, Catherine, and thank you, SIIM, for sponsoring today's panel. What I'd like to start out with is just a quick introduction of who we're having here today, which is really an incredible group. First of all, there are 100 of you, which I think indicates how pressing this topic really is. And in the middle of July to generate this kind of interest says something about the urgency of this topic. And we couldn't have a better group of presenters and different perspectives at that. So as you can see on the slide, we're very privileged to have Dr. McGinty, Geraldine McGinty, join us today. And Dr. McGinty brings a fascinating perspective as an accomplished breast imager and also vigorous patient and physician advocate as her role as Chancellor of the ACR, her work within the Weill Cornell Medical College. And I think she'll be able to bring a perspective of how are some of these advocacy efforts going and where do things stand on that? Pretty interesting stuff. We're very fortunate also to then have Laurie from Cincinnati Children's Hospital, who's going to bring a little bit of a different perspective, but one I think we're going to all find super valuable, which is how do you do this day to day? How do you handle when you're really under a lot of pressure and literally people's lives are on the line as you're trying to get information to clinicians in a vital way? How do you do that? And she's going to have some war stories and some success stories and some tips and tricks and maybe some aspirational things she wished were happening that would make her life and the life of patients and physicians easier as well. And then we have Dr. Mendelson. And Dr. Mendelson, who's Vice Chair of Radiology IT at Mount Sinai in New York City as well, has sort of two unique roles. One is inside his institution, and I think maybe today for us on the panel, he's almost a translator, taking technical ideas and showing how they apply to physicians and patients, and sometimes taking needs from physicians and patients and trying to translate that into actionable information technology concepts. He's also a leader, and he will discuss this a little bit, in the efforts to promote and establish a standards-based way to do this, which I think everyone welcomes, and he will be able to articulate how that works and where that stands. And then finally, my name is Morris Panner. I'm the CEO of Ombra Health, and I bring a little bit of just the vendor perspective of somebody who's trying to understand what the value perspective is of the market that needs this and is trying to fix it. So with that, let's go to the next slide. So we did some surveying, and as a vendor, you get to do this because you try to prove to investors that somebody wants to do what it is you're trying to do. And we went out to patients and surveyed about 1,500 patients and asked them the two questions that you see there and got back a fascinating response. About 4/5 of patients, I actually don't know what the other fifth would like, but 4/5 of the patients wants access to their imaging. And only about a quarter of the people who want it can get it. And to us, that mismatch is what's driving so much of what you hear in the political landscape and in the commercial market today. And I think, I'll be interested to see what our panelists think. My humble perspective is that we have a lot of good data on the impact on outcomes in trauma, telehealth, I'm thinking of telestroke in particular, and second opinion, people trying to access other facilities and other expertise. Feels like there's some real good validation of why this matters, but I'll be curious to see what our panelists think and how it plays out for them. But if I had to quickly in an elevator say, what are the top 3 areas that seem to be affected by this is probably what I'd come back with. And why don't we go to the next slide. And So we also, as you can imagine, one of the things we spend a lot of time doing is calculating what is the return on investment for any kind of an IT solution. We worry about that because if we can't make that argument, it's very difficult for us to be successful. And that's not just us, it's any company. And we did some studies, and there's some studies out there, and you can see the true financial impact of relying on a sort of medium-based transfer mechanism. By that I mean a CD or a flash drive, or I guess some people still use film. But rather than doing a true electronic method of distribution, you can see that hospitals spend real dollars on this. In one industry statistic, what I find fascinating is that hospital systems can spend $100,000 a year on courier costs alone. Real money, if you think about that. And then also, I think increasingly, and you hear this a lot in the EHR, in the electronic health records context, the stress of not being able to get information when you need it is really contributing to what I think is an emerging crisis in the profession, which is the levels of burnout among physicians. They just aren't being able to be the caregivers they want to be and are spending time on something other than what they kind of signed up for. I like to do this at cocktail parties because politics is so toxic these days that I always sort of ask, is there any topic you can think of that we all agree on? And it turns out that, lo and behold, interoperability and the desire for the 21st Century Cures Act, you would find, I think, almost perfect alignment across the political spectrum. I don't know, there are many areas that Vice President Biden, who tragically lost a son and found his cancer care very frustrating precisely because he couldn't get access to imaging, and that President Trump and Seema Verma at CMS would completely agree on. But I think if they were listening to this webinar, if they were on it, they would, there wouldn't be a debate between them. And I think you're going to start seeing out of CMS under the 21st Century Cures Act, the enabling regulations. So soon, this may not just be a good idea and the right thing to do, it may be law. So I think all of these are good reasons to be very engaged on this particular topic. So next slide. So let me introduce our panel. I did already, but I'm going to now give the microphone to each one of them, and they're going to take a few minutes to give their perspective. And we'll start with Dr. McGinty.
Thank you, Morris. Thanks for the opportunity to be here and talk about something about which, as you said, I'm very passionate. And, you know, I'm halfway through my term as chair of the ACR's board, and people ask you, what are you going to do with your time? And, there's an expectation that you'll do big things. And we've got a lot of big things to do, really interesting topics like AI and imaging and making our profession more diverse. But what could be bigger than a patient who has to have their imaging repeated because there's no easy way for us to get their old films? Or what could be bigger than a patient who gets an interpretation that's less than optimal because the radiologist interpreting their exam doesn't have the benefit of their old films? And why are we putting this burden on our patients, making them, navigate yet another complex part of our healthcare system, getting these CDs? And so, that to me seemed like a really big issue. And, I decided I was going to use my platform to see if we could influence the multiple stakeholders in trying to make this better.
Fantastic. And I think there is going to be some supplemental reading material. I thought you wrote a very evocative and powerful piece in the Journal of the American College of Radiology entitled Ditch the Disc, which we can, Catherine, maybe what we should do would be nice if we sent that out along with this presentation, just because why not? And I think it would help articulate how passionately held those views are. If you are okay with that, Dr. McGinty.
I am, of course. Thank you.
Okay, so thank you. So Laurie, would you like to talk for a second? I know you have a slide. You could give a little background and talk through. You gave a great presentation at the SIIM conference, by the way. This year was, I thought, one of the winners of that. So it was great. So take it away.
Thank you. I appreciate the opportunity to participate in this webinar. Yes, I am in the trenches, as you said earlier, and I'm a lead systems analyst on our radiology informatics team at Cincinnati Children's Hospital. We're a big referral center. We get referrals regionally, nationally, even internationally. Last year, we imported over 30,000 studies, outside studies, into our PACS. So we're dealing with this on a daily basis. In my perspective, when I saw ditching the disc as a topic, what I thought about was the alternative. You know, how are we going to get rid of disc? How are we going to do that in the real world perspective that I live in? And I see that as being very difficult. It's, you know, we really need to make electronic imaging work better if we're going to get rid of discs. The reality of that is difficult. We're all implementing our own solutions to get around the inadequacies that we're seeing in the systems that we're using today. The processes, the whole paradigm of electronic imaging needs fixing. So what I'm talking about in regard to problems, first of all, that the vendor cloud systems aren't talking to each other. We haven't gotten that interoperability. And until we do that, it's going to be difficult to get rid of disks. What I've also found and talked about in my presentation last month was that the vendors don't always focus on this, the real need, which is facility to facility transfer. There's been a lot of talk and discussion and implementation over the years that was based on a philosophy that patients would own their own imaging record. And that really has not panned out. Yes, they want access to their images, and they should have access to their images. But as Dr. McGinty said, do they really need to be transporting the images around? First of all, on a disk, but electronically, should we leave that up to patients? And my belief is that the systems need to be built on the concept of transferring images between facilities. Patients want us to do that for them, and they want us to do that efficiently. They want us to get their images there in time for their care, and they want us to do it universally. We at Cincinnati Children's implemented this solution, which we kind of call our multi-gateway approach. Basically, we just install everybody's image sharing gateway so that we can get images on any patient anywhere. But it's really not true. We can't get any images from anywhere because you still have to have this proprietary image sharing gateway software installed at your site. And a lot of hospitals and facilities are too small to do that. They don't have the IT resources. They can't get it through their legal systems. And the reality is that you end up with very inefficient workflow when you can't transfer images at a higher level. If you have to do it by sending emails back and forth and clicking links in emails, exporting images from packs, and then uploading them to a link, that is not universal. It can't be done in the middle of the night when a patient is being transferred from another hospital who doesn't have an image sharing gateway. Trying to send an email in the middle of the night to a CT tech who may not even know he has email. And we've done that before. So my perspective on this is that we need creative ideas. We need vendors with solutions that work in reality, in the real world where we're trying to help our patients. So we'll keep coming up with all these workaround solutions, but they're really just that. Until we get better ways to make electronic image sharing work, we really are not going to be able to get rid of disks.
So super well said, Laurie. And I think one of the things that's nice about this is you can almost see how we're building the cake here. We have Dr. McGinty sort of articulating this as a mandate. The real experience, and I hear the frustration and pain in your voice, which I know is on behalf of clinicians and patients. And so, Dr. Mendelson, I know you have very specific perspectives on how some of this could be alleviated. So I thought it'd be a wonderful transition to you and what you're working on in care quality and the RSNA.
Great. Thank you, Morris, and thank you for the opportunity. And I'm very much going to build upon what Dr. McGinty just went through, and in addition, what Laurie just said. So first, I'm a practicing radiologist at Mount Sinai in New York, and I'm responsible for the IT operation here. So on the ground, this problem is very much in front of me. We import probably close to 100,000 CDs a year throughout our health system, the Mount Sinai health system in New York. And I have multiple FTEs devoted to this, so it's an expense. And it's also slow and inefficient. And I fully agree with what's been articulated is we move movies, music, everything else on the internet electronically today. I would love to see a solution for that mirrored in the imaging domain. With that said, I've been very active through both RSNA and ACR IT committees, focused over the last decade on trying to put in place solutions that would facilitate that. So a lot of what I'm going to talk about on the next 3 slides is, if you go to the next slide for a moment, is really about what started out as the RCA Image Share activity in about 2008. And that was based on NIH financing with a very deliberate focus. The NIH wanted to develop standards-based solutions that were focused on the patient's ability to own and exchange their images. And so very deliberately, we looked at the standards, and the most predominant standard that we focused on was the IHE XDS standard. And we built a solution across several academic institutions that put the images directly in the hands of patients through personal health records that were image-enabled. And that project, which terminated 2 years ago, actually enrolled close to 35,000 patients who had the ability to own their own images in an image-enabled PHR. And from that moment on, they could exchange their images anytime, anywhere, at their own discretion. They did not need the radiology department or the radiology office if it was a private practice. With that said, I was proud of that effort. I think it's very useful, but I also think it's the minority of patients, and I very much agree with the sentiment that was expressed here before. Patients want us to make this easy. They'd like to know that on their request, we can move the images from one facility to another, preferably electronically, preferably quite quickly, not with days of effort and multiple people handling the disks. So with that said, these slides I'm going to show you at this moment are talking about really building an HIE, a Health Information Exchange solution, and the RCA Image Share project has evolved to really try to accomplish this. If you can go back one slide, please. Okay, so how are we going to do that? Well, it's already been emphasized. We need to move from proprietary solutions to standards-based solutions. Standard-based solutions which all the vendors would observe so that they can be interoperable with one another. And we've already heard that ONC is going to facilitate this along with CMS through regulations. It's almost sad that it takes regulations and pricing penalties to enforce this, but that's what seems to be needed. And this doesn't apply just to radiology. It applies to the whole domain of healthcare in general. With that said, I would tell you that we have a wonderful example of where this works. Radiology is eons ahead of the rest of the healthcare world because of DICOM. And so back in the 1990s, finally, everyone got together, vendors, institutions, enterprises, professional organizations, ACR, and the ACR NEMA activity, and we instantiated DICOM 3 as a standard. And that's why, at least within our offices and our departments, all our equipment can speak to each other. We need to do that now, facility to facility, certainly across states, municipalities in the U.S., if not internationally. So the RCA Image Share has moved to trying to define standards which vendors can test against and validate against a formal testing process. So identifying the standards, which are predominantly the IHE standards, having a testing program so vendors can take their solutions, test to make sure they work with one another, and then introduce a trusted framework nationally so that if vendors say we passed the testing, who can we trust to work with? That's a trusted framework. And what we're doing is working with what's called Care Equality, which I view as the network of networks in the United States. They engender millions of transactions monthly across the whole healthcare enterprise. And the RSNA, in partnership with Care Equality, which is an arm of something called the Sequoia Project, is trying to establish a national-based network where independent radiology networks that are standards-based can join and exchange with one another. What does that mean? What that means is if you are a member of an HIE in a city, in my case it would be New York City, if you participate in that environment and you exchange images, you could also exchange with other cities, other municipalities. Many networks in reality for imaging happen to be vendor-based. There's no reason why we can't bring vendor-based networks to the table. And in fact, several of the major vendors who do image exchange are members of Care Equality and could join this network of networks. To make this happen, we have to have something called an implementation guide. It's a description of the transactions that the vendors and the HIEs have to have in place to share with one another. There's a governance model sitting here with care equality. So what would happen is HIEs, the vendor networks, all sign on and agree to abide by this governance model. There's a data use agreement, and it's only one data use agreement that makes it simple. Anybody who signs it can participate. So that's the current activity that the RSNA is trying to instantiate. We have the cooperation of the ACR Ditch the Disc effort. We have several vendors now who are participating with this, and we're hoping to make an announcement at this year's annual RSNA meeting as to bringing this to closure and activating this network of networks for imaging through care equality. Okay, I think that was the slides that I have here. Yes, I just wanted to add that this is really meant to be an easy entry point. There's really only one set of transactions that anybody who wants to participate has to follow, and that's called the Cross-Community Access Profile of IHE. It is, in essence, a gateway, and it's low-hanging fruit because what it says is we don't care what you do under the hood. So if you're a vendor-based network, we don't care if you have hamsters moving the images around, as long as you can abide by this one IHE profile, which tells you how to connect to other networks, you're good to go. And there will be testing around this one profile. And I think that concludes what I had to say here. Thank you, Morris.
Perfect. So thank you. That is that really sets us up well, I think, for what now is a little bit of a kind of Q&A and interaction between the panelists, who all have slightly different perspectives. And then I have to say, somehow my perspective creeps into this, because I noticed that our first broad topic is ditch the disc to save time and money, which somehow managed to make itself ahead in the order of ditch the disc to improve patient care. So certainly there's some vendor perspective here that has polluted the whole effort. So I apologize for that. But let's start with saving time and money, because maybe that does contribute to patient care and moves us along. So, you know, I talked at the beginning about the impact of cost on sharing and burning disks and everything else. And, you know, I thought what might be nice is, you know, Dr. McGinty, you see a lot of what's happening in terms of some of the contracting and some of the business arrangements in your health system. What's your perspective on how this is driving cost and driving inconvenience? And what's your perspective around that?
Well, first of all, Morris, I would say that we can certainly cast the issue of cost and inconvenience as a patient issue, right? You know, I've seen calculations that say it costs, you know, up to $100 for a patient to even come for an appointment, when you think of the fact that they have to leave work, the fact that they have to travel. So, you know, when we're making them make an extra trip to get their CD, then we're certainly layering costs onto our patients. And we know that our patients are already bearing more of the cost of their care. But, you know, as we look for opportunities to improve the efficiency of the care we give and spend more of our healthcare dollar on giving patient care, this is exactly the kind of unnecessary cost that we should try and remove from the system. You know, I want to make sure that we are maximizing the amount of resources we devote to our patients, and this seems to me to be, you know, clearly not the best use of those resources.
Yeah, I agree with you, and thank you for that perspective. I do think from a patient point of view sometimes, and maybe this is part of the national debate about healthcare too, saving time and money is turning into one of the critical barriers to access. And you can't have patient care if you can't get any. So that is really a pretty important feature of the whole piece. You know, maybe, does anyone else have any comment around that, or we can keep going? I'm sort of throwing some questions up on the screen, and then as audience members have them, feel free to put them into the chat window, and we will bring those to bear as well. But I'm going to sort of keep it going for a little while, just because I had a lot of questions for these panelists. So anyone else on question one?
Yeah, this is David, and I just wanted to add, in addition to the cost that probably is passed down to the patient ultimately, There's the time and inconvenience factor, and I have found that generally the patients who most need to move images from one place to another are usually the sickest patients. And what they want to focus on is their illness, often a severe illness. And what we've introduced is just something that is a major distraction and prevents them from, just expediting the care that they need, because what they have to figure out how to transfer medical records, not just images, and it can take days to weeks sometimes for them just to aggregate the information for a second opinion, a consultation, or a surgical procedure. And it's just a major hindrance on their emotional state.
Yeah, I agree. And what's interesting, actually, you just made sense of our survey in a way. I think people who have imaging are often, it's a little binary. If your imaging is benign, if there's nothing to talk about, you don't care that much about getting access to it. It's a test and it was negative, and that's wonderful. If you do have anything that you need to act on, it probably is one of the most important parts of your healthcare record from then on, which I think people don't understand. They think your healthcare record is words the physician writes in the computer now, and it really is something she does more electronically and is really very visual. So,
Morris, if I may, can I just add something to what you just said, though? That what's normal for you can be very much dependent on that continuity of looking at your old images. And for someone who goes to a new facility who has, eventually what turns out to be an incidental finding of a cyst in their liver that perhaps looks a little atypical, we risk adding additional unnecessary testing. We certainly risk making the patient anxious. And imagine if that's a patient who's had a cancer diagnosis, that your normal is something that we really only start to know as we look at the whole continuum of your imaging. So when we see you for an isolated incident without those old films, we can cause extra testing and significant anxiety.
That is a perfect segue to question 2, because I think I happen to be a parent, and I've actually had to avail myself, unfortunately, at different times of the services of children's hospitals. And I think that group of people who are bringing children, the children are extremely anxious and the parents are extremely anxious. And it just feels like we're not doing ourselves any favors. And Laurie, you kind of alluded to this in your presentation, but maybe you could talk a little bit about where we sit compared to other industries and how some of these interoperability questions factor in against some of what Dr. McGinty and Dr. Mendelson were referencing.
Yeah, I think that, healthcare definitely lags behind other industries. We can go online and download music. All the entertainment related things have advanced so dramatically. But when it comes to imaging in healthcare, we just haven't really gotten there over the years. We're still lagging so far behind. And I think a lot of it goes back to what I was saying a little while ago in regard to why do we still have CDs? If we start looking at that, why haven't we been able to get rid of CDs yet? Why are we lagging behind and not able to transfer medical records easily and efficiently and universally? And I think that's a lot of the problem is that interoperability issue and not having a standards-based approach to it. All of the proprietary software makes it very difficult. You can come up with a solution that works at your facility. You can make it more efficient. You can try your best for your patients, but you're still dealing with so much difficulty and expense. Going back to the other question, every time you get a disc that's difficult, it takes time on your staff who are routinely managing those incoming discs. They can't import a particular disc, and for example, an encrypted disc. Some hospitals, in the sake of what they're calling security, encrypt their CDs, and they send those to our hospital, to all the hospitals their patients are going to. They give that disc to their patients. Their patient can't view that disc because they don't know how to unencrypt it. Might even have a password on it. The password was typed incorrectly, so no one knows how to get to those images, and we can't import those images. So it stops the routine workflow. A phone call or a support ticket has to be placed, and someone on the informatics team has to go physically pick up that disk, bring it back down to their desk, and find some way to get those images into the system. And we need to get them in because, as you said, it's the sickest patients who need those studies in our systems. And we can't pick and choose that we want, well, this disc for that patient we could get in, but we've got these other CTs that are a little older. Do we decide that we're just not going to import those because they're difficult? We don't, because we care. And so we spend all of this time and energy attempting to accomplish that for the patient. So yeah, I think we lag behind, and I think a lot of it has to do with the state of the industry and the state of electronic image sharing.
I don't know if anyone wants to jump in on this, or if not, I can go to question 3. Okay, all right, fire it up.
I don't know how the conversation, but you know what? I'm going to accuse us as a healthcare ecosystem of just not having stepped up on this. I mean, huge amount of work that we've seen, as David mentioned, you know, getting the technology right. And I think we're in a very different place, both thanks to the efforts of organizations like RSNA, but also what's happened in the industry. But I think that what we're missing is some of the aligned incentives and regulations. And I think we have to be candid that, you know, it's not always the first thing on the mind of a health system of how to make it easier for their patients to go elsewhere for imaging. And I think that also to be a little kinder, you know, we're all busy. We've all had a lot of other regulations layered on and a lot of other complexities that we have to deal with. So we've pushed this down the list because at the end of the day, it may impact the bottom line a little bit on cost, but the people it impacts most are our patients. And I just think that we just haven't put them at the center of this in the way that we should have.
Yeah, I agree. So the most important stakeholder is the patient, but they're probably the weakest stakeholder. And historically, there have been things like information blocking pervasive throughout the healthcare enterprise, and we are overregulated on many things. And you've listed security here as a concern, Morris. Security is a concern, but maybe it's overstated. Interestingly, when we did the RCA Image Share project dealing with the personal health record, and we spent the first year focused totally on it, trying to make the most secure environment we could. And after we were all done, we found many patients posting their images on Facebook. So it may be the medical community and the legal community has overemphasized security. I'm not an advocate of just a free-for-all at all, but maybe the HIPAA regulations are almost a little too stringent, if you will. At any rate, I think the good news is, as ONC has now focused on interoperability, some of the information blocking across the board will begin to dissipate. And the solutions that industry uses are very dynamic in IT these days. Healthcare is a little slower because of some of the regulatory issues that we face. This may be a case where perfection is the enemy of good. There are good technical solutions identified. They will evolve, and they always will evolve. We've got to kind of step in somewhere along the line, put a system in place, and then let the technology evolve at a reasonable pace.
Nice. It's sort of interesting. Not to harp on this theme, but I like the fact that we put saving time and money first, because what I just heard was a pretty candid assessment that maybe some of the things that we say we value the most, sometimes when I look at a healthcare system, it feels like I'm curious. Information blocking has come up. All these issues do come up, and there are business issues, and there are questions around who shares and how, and that applies to vendors. It applies to healthcare systems. And it's interesting that the patient doesn't really have much of a voice in that, because they're a little bit at the mercy of the system they're presented with, and probably are in a setting where they'll take any care they can get at some level, and they'd like the best, but a lot of the times people are pretty desperate. So I think it's a very nice acknowledgement that the industry writ large, which is a complex ecosystem, needs to do better serving the people that, as Laurie said, it's because we care. And I've always had that experience in the healthcare system. Let me go to question 3, which in some ways I feel almost we've covered a little bit, but does anybody want to add more about how the CDs affect the daily workflow of administrators and physicians? I feel like we may have gotten a lot of those ideas across, but are we missing an element that people should understand, or maybe even a solution or some experience that would be useful for our audience today? Happy to keep moving if that's not the case, because I know we've heard a lot about that one issue.
This is Laurie. I can probably add one thing to that, or a little bit. So we know how inefficient CDs are. They're terribly inefficient, and we can tell stories about things that happen on a regular basis that slow us down. CDs that show up with the patient that never make it to the provider, don't get into the PACS, they don't know how to use the software, all kinds of things like that. But I think there's the other aspect of workflow around electronic imaging. And I don't know that anyone's talking about this very much, but electronic images are often transferred, when you think of facility, they go to radiology or cardiology. And radiology, in our environment, we simply import those studies into the PACS. There's no communication back to the clinical departments who maybe requested those images in the first place. And I think it's something we have to be cognizant of. We need systems that allow us to distribute workflow out to clinical departments, because they have always owned that CD workflow. They have workflow dependent on it. They might have the process where they schedule appointments for the patient when they receive the images. Or maybe they don't even create the patient in the medical record until they receive the images. If radiology tries to import those images, there's no patient to import them to. So we end up having to create some fake medical record number, and then no one can find the patient. So I think we have to be cognizant of the fact that when we try to build this universal or standard approach to electronic imaging, that there's workflow that goes around it, and that we need to make sure we're incorporating that.
Super interesting point. So it's not just getting the image to the door, it's then being able to incorporate it to the point of care. And there's issues, the idea of a quote unquote fake medical record just to get somebody in the door and then try to reconcile it after. I think the average patient would be somewhat flummoxed that that's what's standing between them and their physician. But it sounds like that's a real and current challenge.
So import workflow is very important in the overall issue and overall problem. But the CD itself, if we could conquer this issue around the CD and move to electronic transfer, the fact that it's a physical media that needs to be moved, that really is probably the longest time constraint that we have here. It introduces the longest time interval of moving the data around. But Laurie's completely right. It's even if you didn't have to deal with the CD, you still have to figure out how to best put it in the hands of the people the information in the hands of the people who need to look at it.
I'm going to go off the board here for a second, which always probably makes everybody nervous, but we do have some audience participants who are starting to send in questions, and I always like to bring that to bear. And one of the questions, I'm going to reinterpret it a little bit and ask it first to Dr. McGinty, but then to others. And it's spurred a little bit by what Laurie had said. And it's a question around, if you're in a facility outside of a particular geographic area, is there a universal list of people who accept electronic exchanges? Or, we have someone who's requesting this kind of question from Florida saying, is there a list of places that I can share with and send to? How do you navigate that today?
Well, we don't.
Okay, so I think that's the essence a little bit. There is no kind of, the American College of Radiology doesn't have a list, RSNA doesn't have a list. There's no list today that you can go to in a directory fashion. You really have to kind of piecemeal it together. And maybe this is also for Laurie, when people are trying to send to you, a lot of manual work, or what do you do?
And Morris, if I may, I think this is, if you thinking for the future, how might we align incentives around this? So in our world at the ACR, there's a list when you want to get a lung cancer screening CT or a mammogram, or you want to go to an accredited facility, you can come to our website and we'll tell you where you can do that in your area. Is that something we should be thinking about as a differentiator for a practice? This is a practice, who can receive and share your images electronically. I mean, that's the kind of thing I think we're going to have to think about to really move the needle on this.
I love it. So this is, so you could there are lists for different kinds of things, and maybe this is another list that needs to exist.
The proposed mechanism of care equality is that each network that participates on care equality exposes their list of patients to the other participants on care equality. So there's a presumption that the patient is consented to share, and that's usually handled within each of these individual networks. Once the consent is there, each of the participating networks publishes its list, its EMPI, if you will, and that's searchable quite quickly electronically. And it's not in place for imaging yet. That's what we're hoping to achieve. It is in place to some extent for some of the EHRs. So Epic and Cerner are all participants in care equality and exposing their patient participant lists online.
Perfect. So it sounds like it's interesting because the topic resonates. These are the questions that are probably been the hardest to make it all sort of work. But when you ask the most common sense question around, well, where's the list? It instantly exposes, a real area of opportunity, which is, I think, fantastic. I think it's worth, one of the things, this is now I'd like to move to question 4. One of the things that I think is worth chatting a little bit about is so much of image transfer comes up in the context of regional centers of excellence and people seeking advanced care. And I'd just be curious, how do you, this is a little bit of, maybe even if you can get something, how does it go back? What's the workflow today if you're seeking care from a center of excellence? And I don't know if you want to start, Dr. McGinty, around what are some of the best practices for that? And, we're fortunate that we have representatives from 3 of the top healthcare systems in the world who get a lot of inbound traffic that isn't just people who live necessarily in their immediate neighborhood.
Well, obviously, as you mentioned, I'm in a referral center in New York, and my wonderful colleagues are experts that people do indeed come from around the country and around the world or want to consult them. So we have set up a whole infrastructure about making those kinds of second opinions available. But again, it requires time and effort, and I think goes actually far beyond the imaging. Sometimes actually the imaging is the most straightforward. Collating all of the notes and putting the context together for the record is definitely something that it requires a lot of infrastructure.
Others want to chime in there, or?
Well, this is Laurie. I think I would make one statement about the question, in that it isn't the physicians who are transferring the images, it's the facilities. The physicians are the consumers of those images. But they don't want to be involved in the transfer of the images. They don't necessarily even want to be involved in deciding whether the images are valuable enough to send to the PACS. At our facility, we actually send every single study we receive to PACS, because our director, his thought on that is that you can't know when you're importing the images whether they'll be needed for the patient's care in the future. And so my premise is that physicians are not doing this. It's the facilities that need to be transferring.
Perfect. So I do think there is a lot of steps in this. It's a little bit of a team effort to move information. I think that makes a good transition over to our next section, which is really thinking about how all this then ends up improving patient care. And sort of the first question I'd have around this is, I think a popular thing for patients is we hear a lot about patient portals. We hear a lot about these various systems. where does imaging fit into all of that, or how does it fit into all of that? And, you know, Dr. Mendelson, maybe you want to start there and talk a little bit about it. I know you run big systems that have a lot of different components of the healthcare record, and I'm just curious.
Sure. So this really varies, I think, from site to site. Some of it is under regulation. So the radiology report is part of a suite of information that, to get meaningful use dollars, enterprises were obligated to expose the report within 3 days. You can have exceptions to how you do that. Here at Mount Sinai, a release of the radiology report in advance of 7 days is at the discretion of the ordering provider, but ultimately it's released either way. The images themselves, that's quite interesting. So I did talk about the image-enabled personal health record, and we still participate in that here at Mount Sinai for patients who ask. We offer it. We let people know up front that it's available. Certainly anyone who wants a CD today at our request, I need to take my images out of here. CD is offered. The image-enabled PHR solution is offered. So patients certainly have access. We are all legally obligated to provide access throughout most of the United States. And there are imaging portals that are delivered to radiology practices. So many large practices have invested in solutions where patients can sign into the PACS system of that practice and look directly at their own images. So there's a lot of variation today in that regard. But I think we've come a long way to enabling it.
Interesting. Okay. Anyone else have a sort of different perspective on how that works today?
I will just say that our experience is quite similar to Dr. Mendelson's. But one of the things that we offer at Weill Cornell is a patient consult service. So if a patient wants to talk about their results with a radiologist, they can do that. We put a phone number in the report. But what we're hoping to do with our patient image portal is really encourage patients to start using that facility.
Yes, we're saying Children's were in a similar situation. We're actually in the process of implementing the ability for patients to view their own images. I think one thing to think about in that area is then moving that portal to the next step. I mean, patients being able to download those images and do something with them once they get the images if they wanted to. And then also the next step of uploading images and keeping that in mind that, you know, once patients do have discs today, they have their images, they're moving them around, then we need to find ways for them to upload those images. And with enterprise imaging growing dramatically, we need to also keep in mind that to upload the images, you need to have ways to distribute them to the correct departments. And so thinking along those lines as we move towards patient portals.
So this is great. And I'm gonna go off the board again, and we're getting a fair number of audience questions. And this one is just really on point to the conversation we're having, which is some ideas on best practices. Now, this is asking, I assume, from a system that's trying to implement the right kind of approach to this. When they get outside imaging, what's the best practice around retaining that? All of your institutions generate a lot of imaging inside of their institution, so I understand those rules. But what about when you get these outside images? What kind of expectation, what should the facility do, and what kind of expectation should people have around their imaging record at a facility? And who would like to start? You jump in. I'm going to throw the ball up and see who grabs it.
So Laurie expressed it very well, and at Mount Sinai we're doing the same thing she described at Cincinnati Children's. Every image that is imported is put into PACS permanently under the patient medical record number and jacket, so it's there because you never know what value it has down the road. So we're following that mantra.
And Dr. McGinty, do you have a perspective on that? So we're 2 for 3. Are you going to go make it 3 for 3 or different views?
I'm just gonna encourage us to be pretty aspirational on this. You know, I think I, as a patient, should expect to be able to access my data when I need it, where I need it. I'm not an informaticist, but I think if I look at, for example, some of the platforms that I use to aggregate my financial accounts, I expect that kind of accessibility to my data and the ability to do that wherever I need it.
I think that's pretty helpful. So it sounds like there are sort of two sides of the coin. From the patient perspective, it sounds like it's a pretty powerful thing to be able to tell the patient that once you have uploaded imaging, it's part of your record and there's a way to get it. And it also sounds like from a clinical point of view, often that is the recommendation. It sounds like both Cincinnati Children's and Mount Sinai and others do create that and allow what Dr. McGinty describes as the aspirational side of it to be implemented. So that's super helpful and I think very important. Now, full disclosure for both our panelists and the audience, our deck that we're going to be circulating to you has questions we haven't gotten to. And in some ways that's because I'm a bad moderator, but I also think it's because I really like the fact that the conversation we've had has been so rich, and I didn't want to lose time for the audience questions. So when you get this deck, you'll see there's some questions that we have not gotten to. But one of the nice things is I think all of the participants in the webinar, and certainly through SIIM, are open to continuing the dialogue, as are we after. So certainly through us, we're happy to route questions as needed to the various panelists. So anyway, but let us move on. We're have another 5 or 6 minutes or so. So if you have questions, please send them in because we're getting close to the point where we will have to wrap up. So let me just kind of go on to one other question, which is from the patient point of view, as you're starting to think about these systems, what kind of education is required for the patient population, or is that not an issue? And maybe, Laurie, maybe we'll start with you. And you have an active population. It's not always something you can predict because there is so many people coming from outside of your geography. How do you approach this?
Well, I would say that, yeah, education is necessary, but as a person who has done a lot of training in my time, I would say it's very difficult to actually educate patients. When they're in a system, you need overlays. You need something that's right in front of your face in order to help people understand how to use the software. It's often very complex software. You have to plan the design of the interface around the user. And in fact, in our patient portal, we've actually done that and taken away a lot of the complex buttons, left just really simple things like window level, zoom, and scroll, and try to make it as simple as possible. But I think making things intuitive and easy is a better plan than educating. You have to educate patients that this is available, and you definitely have to find a way to get that information into their hands as part of their care in your institution. But once they get there, I would say it needs to be intuitive rather than education at that point.
Others have a view on the patient side of the equation.
Sure, Morris, I will say that I often have to talk to my patients about the fact that the comparison with their prior mammogram can be essential, and that I might have to do additional pictures, but if I had your old films, or your old images, I'm betraying my age there. If I had your old images, I might not need to do those, or that there might be something I don't even notice unless I'm looking at it as a change from your prior images, and that's not necessarily something I would expect our patients to understand intuitively.
Yeah, I agree with that. I think the patients and the providers, for that matter, including the radiologists, don't want to have to know the details of this at all. To me, the analogy has always been money. We know you walk up to an ATM machine, you just know you want your money, and you don't care about the transactions and the intermediaries in the background. You just want to know that within a minute or two, you can get what's yours. And in this case, I think the patient only wants to have knowledge of the medical issues that they're confronting, not how people handle the paperwork and the the motion of the data in the background, that should be a trivial issue as far as the patient's concerned, and for that matter, as far as the referring provider and often the radiologist is concerned. Let's focus on what we've been trained to do as a physician is, make some decisions about delivering the best care to the patient, not how electronically the data moved.
Yeah, I would agree with that.
Okay.
I think making sure that patients are sort of out of that, really. They shouldn't be part of that, the whole process of knowing how the images move, as Dr. Mendelson said. We need our clinical departments, our clinical care providers to incorporate outside imaging into their process of bringing patients into their clinics and into their practices. It needs to be common that we request outside images and then we bring those images in, and patients should just be able to expect that they're going to be there when they're needed.
Fantastic. And we're really right up against it. We've got about 2 minutes left. This is one of those impossible questions, but why don't I give each of you just 20 seconds, and maybe Dr. Mendelson, we'll start with you. Just any last thoughts, and then I'll give the final words here and fire it up.
Yes, thank you, Morris, for the opportunity. And basically, you were asked about best practices, and what I would encourage those on the phone to do is whatever vendors you're dealing with for your PACS, for your RIS system, or image exchange specifically in CD burning, encourage them now to become standards-based. I'm a little bit less interested in whether they validate with the RSNA image share, but they should be following those standards. If they follow those standards and others do the same, all these sites should be able to transfer fairly easily. And so I'm a big advocate of this care quality project that we have going.
And Laurie, how about?
I would probably just add that as we go through this process, and on all of us as customers of the vendors that we use, we need to keep pushing them, as said, and beyond just the standard capabilities. So now we've got the ability to install an image sharing gateway. We need to make sure that we can share images with more than just paying customers of that vendor. We need to make sure that that vendor is building in user interfaces that are easy and intuitive to use, and that they're thinking about the peripherals, such as communication. How do we know the images arrived, and how do we communicate that out to the referring providers in the emergency room who need to know that those images arrived? How do we communicate it to the people in radiology who have to import the images to the PACS? All of those peripheral things that are part of these systems, we need to start making the systems better and more universal and more easy to use for our radiology departments and for our clinical providers.
And fantastic. And Dr. McGinty, you'll get the last word before we do all the credit stuff. So everybody who's on this to get credit, you'll get it. But Dr. McGinty, I'd love to hear some closing thoughts.
Thank you. Our department really has an overarching philosophy that's about putting the patients first, as I know most of us in healthcare do. But David said it, our patients are the most important stakeholder, but they're probably the least influential. So I think really it's incumbent on all of us to think about this through their eyes, through their lens. And that's leadership. That's making change on behalf of the people we serve.
So I couldn't have thought of a better hour of what you just said, leadership and trying to make change. And thank you all for participating. And a special thanks to our panelists. Your time is so precious. People give their right arms literally to come see you guys, and for you to share your wisdom is really spectacular. So thank you. Catherine, why don't I turn it over to you, because I want to make sure everyone who's attended this can get the appropriate announcements that they need.
Yes, thank you, Morris. Again, as we mentioned, if we didn't get to your question, we'll be sure to reach out after this webinar. And SIIM will also have the webinar for SIIM members under their education section. Ambra Health will be sending out the recording and the slides. Additionally, if you stay on here for just a minute, a brief survey will pop up. Just click on the closed webinar pop-up to access the online survey. And SIIM members are also eligible to receive SIIM IIP credits towards ABII certification and recertification. If you would like to receive these credits for participation, just complete the survey at the end, and SIIM will be sure to send those over to you. Thank you, everyone, for hanging on with us until the end. Have a great day.
Thank you all so much.
Thanks, everybody.
Thank you very much.
Thank you.